So at the outset, I would like to thank Bhargav for the opportunity. So in this webinar, basically as Bhargav just told, so we shall be discussing about the evidence-based selection decision making in the treatment of early glottic cancer between radiotherapy and transoral laser surgery. Basically, which are those select subset of early glottic cancer which will benefit by transoral laser surgery, and which are those subset of early glottic cancer we should not contemplate doing a transoral laser surgery. As we all know, laryngeal cancer is one of the commonest cancer we come across in the clinic on a regular basis. Fortunately, this vocal cord is a very sensitive subsite. So any lesion which is quite small will be present as a change in voice. As a result, the patient will go seeking advice from an ENT doctor, and with an endoscopy, the lesion gets picked up early. Even anatomically, the vocal cord has a very sparse lymphatics. As a result, these subset of patient have an excellent outcome. Unlike other subsite in the head and neck, because these has a very sparse lymphatics, there is no need to prophylactically treat the neck. So the treatment, the curative intent treatment involves only treatment of the primary in this subsite. Unlike supraglottic tumors, which are a different subset of tumors, anatomically, they have a higher lymphatics, and even in the early stage lesions of the supraglottic tumors, they have a propensity to have a occult lymph nodal metastasis, and those tumors needs to be treated both at the primary as well as the neck. Currently, the standard treatment for supraglottic tumors is radiation for the primary as well as the neck, and the role of surgery is very limited. In experts' hand, the supraglottic tumors can be contemplated in by transoral laser surgery, but the current topic we shall discuss mainly on early glottic cancer. So traditionally, we are exposed to an anatomy of an open approach, that is outside in, coming from an external skin going inside. But when we want to contemplate transoral laser surgery, we need to understand the anatomy inside out. So the vocal cord, as you all know, is formed by the free edge of the conus elasticus that extends from the cricoid to the thyroid cartilage, and the free edge of the conus elasticus forms the true vocal cord. And what constitutes the true vocal cord? You have a stratified squamous epithelium, and deep to the stratified squamous epithelium, you have connective tissue layer which acts as barriers or compartments to prevent the spread of tumors. So deep to the epithelium, you have the lamina propria. The superficial lamina propria forms the Rinke space, and the intermediate and the deep condenses together to form the vocal ligament. And deep to the vocal ligament, you have the vocalis muscle formed by the thyroarytenoid. So all of the early glottic cancers are limited to these layers of the vocal cord, that is the epithelium, the lamina propria, and certain situations when patients present with some impaired mobility, there might be some early involvement of the vocalis muscle. So vocal cord is functionally a very important organ. It helps a great deal in speech and voice production. It also helps in swallowing by with the elevation of the larynx, opening of the cricopharynx, as well as coordinated movements of the vocal cord helps a great deal in swallowing. In addition to that, it has a function of protecting the airway, breathing, and maintaining the airway patency. So vocal cord are staged from stage T1 to T4. T4 is usually treated with the palliative treatment. T4A, when the tumor comes out of the laryngeal framework, they get treated with surgery in the form of laryngectomy followed by adjuvant therapy. T3 set of tumors get treated with chemoradiation with the intent of organ preservation. So our interest today in this topic is this group of tumors, that is T1 to T2 tumors. T1 again is divided into T1A and T1B. T1A meaning the tumor is limited to one vocal cord. T1B means the tumor involves both the vocal cord. And T2 meaning the tumor extends either to the supraglottis and subglottis or subglottis with or without impaired vocal cord mobility. So the traditional treatment options for early glottic cancers are the external beam radiotherapy, or in the surgery, you have the conservative laryngeal surgery or the transoral laser microsurgery. So generally, in the Indian scenario, majority of these patients of early glottic cancer gets treated with external beam radiotherapy. The reason being, for a T1 vocal cord cancer, the local control rate are more than 90% when you treat with therapy. For a T2 tumor, it has a local control rate of around 70 to 80%. The reason for a universal use of radiotherapy is that it is easily available across India, and you have trained radiation oncologists across the country. And obviously, there is no need of the surgery, so patient kinds of opts for this kind of a treatment. You know from data from 20 years back that radiotherapy has better voice outcomes than open conservative laryngeal surgery. So conservative laryngeal surgery is a time-tested treatment approach, and it has been tried in a variety of extensive lesions, that is even bulky T2 lesions when it's extending to the ventricle, when it extends to the subglottis, or when there is an anterior commissure extension, which is generally a poor prognostic factor. Even though when there is a supracommissure or a subcommissural extension, the conservative laryngeal surgery has reasonable good outcomes. It also has good oncological outcomes, and the lesion is significantly involving the ocalis muscle, or even for extension beyond ocalis, but limited to the larynx. So this has been proved in terms of local control, local regional control, laryngeal function preservation, as well as laryngectomy-free survival. However, there are problems with this kind of a surgical approach. There has been significant morbidity in terms of they have a stormy postoperative period. There is significant aspiration in the postoperative period. There is delayed swallowing, needing prolonged nasogastric feeding, need for a tracheostomy for a certain period of time. And once they are off tracheostomy also, they tend to have a poor quality of life, poor quality of voice, and this leads to an increased length of stay in the hospital and increased cost of treatment. As a result, currently, there is a declining use of practicing conservative open laryngeal surgery in early glottic cancers. So the current options available to choose in the management of early glottic cancers are between external beam radiotherapy and transoral laser microsurgery. So when deciding between the two, we need to concentrate on these factors. The most important factor in deciding treatment between the two is oncological outcome, to see if transoral laser surgery has equal oncological outcomes compared to radiotherapy. And if at all, if it has equal oncological control, how does it fare in function preservation? Does it have an equal voice outcomes? And what are the larynx preservation rates compared to radiotherapy? In addition, in Indian scenario, cost is a very important factor in decision making. So to decide treatment, obviously we go to evidence. Unfortunately, in early glottic cancers, there is no randomized trial head-on comparing radiotherapy, randomized trials which had been initiated, like the Easter trial. Unfortunately, the trial has to be closed due to difficult recruitment of patients. So what is the current data available for us to make decisions? So we have large series, prospective series or retrospective series comparing radiation versus transoral surgery, and we have meta-analysis and reviews on these prospective and retrospective series, and hence we have to rely on these evidences to make our decisions. So transoral laser surgery, as you all know, was initially started by Strong and Jacko. So he's the first one to couple the laser surgery, carbon dioxide laser to the microscope. And after that, there have been significant technical advances in the types of laser available, as well as the microscopes, and better understanding of the techniques by the pioneering work done by Steiner, Peretti, Petra Ambrosch, and other senior experts in laser surgery. So Steiner has published his large series of around 159 cases on early glottic cancers done between 1979 to 91, where he initially showed that transoral laser surgery is a oncologically safe surgery to be performed for early glottic cancers. And after which there have been large prospective as well as retrospective series looking at outcomes in terms of local control and larynx preservation. And we know that for a patients treated with transoral laser microsurgery for a T1 glottic cancer, the local control rate is upward of 95%, and the larynx preservation rate is also in the range more than 95%. And it is this data is from across the world. And even though the laser surgery has been initially started in the Europe, slowly the American and even the India, we have a good number of data to substantiate that T1 glottic cancer do well with transoral laser microsurgery. Coming to the T2 early glottic cancer. So T2 early glottic cancer treated with transoral laser surgery has a local control rate between 80 to 90% and a larynx preservation rate upwards of 90%. So how does it fare when you look at the patients treated with radiotherapy? For a T1 early glottic cancer, the local control rate is comparable to that of radiotherapy, with the larynx preservation rate also similar to that of transoral laser microsurgery. For a T1 glottic cancer, based on these data, it looks like oncologically both transoral laser surgery as well as radiotherapy fares in a similar manner. However, when you look at the T2 glottic cancer, the local control dips down slightly between 60 to 75%, and even the laryngeal preservation rate is just around 80%. So there are about 5 or 6 systemic review and meta-analysis. None of them clearly gives an answer to tell which one is superior to other, but there are certain articles which show there is a trend for transoral laser surgery to be better in early glottic like T1 cancers, but these are not strong evidence. Currently, based on the evidence available, early glottic cancer in terms of oncological outcomes fare similarly between radiation as well as transoral laser microsurgery. So even though the vocal cord has a favorable outcomes, there is a small minority of patients who fail. So we look at the recurrence rate, patients treated with radiation, T1 lesions has a recurrence rate of around 5 to 20%. For a T2 lesion, the recurrence rate is around between 25 to 30%. When the patients treated with transoral laser microsurgery, the recurrence rate is around 10 to 15%. So this is a very good meta-analysis on looking at predictors of local recurrence in patients treated with radiotherapy. So it looked at about 27 studies, and what they found out was T2 tumors with anterior commissure involvement and bulky tumors, along with male gender, low hemoglobin levels, and history of tobacco consumption after the completion of treatment, all of these were poor predictors for local recurrence. ASCO has also clearly grouped a subset of T2 patients which are unfavorable, meaning the lesions which are deeply invasive in radiology as well as endoscopy in the form of impaired vocal cord mobility. So these unfavorable tumors fare badly irrespective of the treatment approach, whether it's treated with radiotherapy or if it is treated with transoral laser surgery, both fare very badly. What is interesting to note that if a patient had a recurrence following radiotherapy, post-operative follow-up, or generally patients treated with for vocal cord cancer with radiotherapy, the follow-up becomes a bit tricky because on endoscopy, it is difficult to assess the tumor reappearance because of the inflammatory changes associated with RT. It is also difficult to pick this lesion on imaging because of the artifacts of radiation. And whenever these tumors come back, they are usually multicentric and they have about perineural invasion in about more than 50% of patients. As a result, the recurrent laryngeal carcinoma following radiotherapy in early glottic cancers end up in a total laryngectomy in more than 80% of patients. So as a result, the organ preservation rate decreases when for radiotherapy treated patients. However, the recurrence occurring in a patients treated with transoral laser surgery, we have got multiple options. We can go and re-laser these patients. We can consider open conservative laryngeal surgery, or we can use radiotherapy for curing these patients. As a result, the organ preservation rate for patients treated with transoral laser surgery is around 90%, whereas patients treated with radiotherapy, the organ preservation rate is around 70 to 80%. So this is a very interesting study which looked at the prognostic impact of initial treatment in surgically salvaged recurrences for early glottic cancer. And what they found was that the patients who were treated with radiotherapy as a first modality of treatment fared badly in terms of overall survival and disease-specific survival. In addition, these patients had more complications. They had a longer decannulation, prolonged feeding tube dependence after the salvage treatment. So what are the factors which predicts failure in transoral laser surgery? So understanding these factors are very important so that we choose our patients appropriately to give the best outcomes. So various studies looked into the factors predicting failure in transoral laser microsurgery, and they found that difficult laryngeal exposure, anterior commissure involvement, posterior paraglottic space involvement, arytenoid cartilage invasion, previous microlaryngoscopy surgery, and positive surgical margin, that is deep margin positive or multiple superficial margin positive, were all poor prognostic factors for local control for transoral laser microsurgery. We'll take one by one. So first, coming to the difficult laryngeal exposure. As surgeon, the most important factor for attaining negative margin is good exposure, especially when you're dealing with vocal cord surgery, where we need to work in a narrow confines through the laryngoscope. It is very important to have a good exposure. And they found that patients with difficult laryngeal exposure fared poorly in local control, and the factors which affected the difficult laryngeal exposure were limited mouth opening, receding lower jaw, short or a stiff neck, marked obesity, and large tongue. Can this be predicted preoperatively? The group from the Peretti group from Italy, Piazza and Peretti, they looked into preoperative variables to predict laryngeal exposure. They took about 11 parameters, which included interincisor gap, thyromental distance, upper jaw dental status, trismus, mandibular prognathism, macroglossia, micrognathia, degree of neck flexion, history of radiotherapy, etc. And based on this, they developed a scoring system, and they divided based on these scores, they divided it into 5 classes. So 0 is when there was a good visualization of anterior commissure with a large bore laryngoscope. 1 was when, with the help of an anterior pressure, we could have an adequate exposure on the anterior commissure. Class 2 was when, with the flexion position, the anterior commissure exposure was adequate. And class 3 and class 4, class 3 wherein we had to change to a smaller laryngoscope, and class 4 where anterior commissure was very difficult to visualize. And this kind of predicted the margin clearance as well as oncological outcomes. At our center, we are currently following this laryngoscore in our transoral laser surgery patients, and we find it very useful in predicting the anterior commissure exposure, thereby helping in counseling our patients when we discuss the treatment with them. Next most important factor is involvement of the anterior commissure. The anterior commissure involvement either with radiotherapy or surgery fares badly. So there are studies from multiple high volume centers which show that when the anterior commissure involvement was there, then the local recurrence rates were high. Why this happens? Because anterior commissure is anatomically a very difficult site to get exposure in laryngoscopy. In addition, anatomically, there is absence of perichondrium in the attachment of the vocal cord, near the attachment of the vocal cord to the thyroid cartilage. Hence, there is a chance of extension which cannot be picked up in just routine endoscopies. And studies have shown that when you just do an endoscopic evaluation, we generally tend to understage these lesions. Hence, along with this endoscopic evaluation, if the lesion extends to the anterior commissure, it is mandatory to get a serial 1 millimeter sectioning of the from the superior notch of the thyroid to the cricoid to properly evaluate the extent. And we need to evaluate these scans both in axial as well as sagittal scans, because a lesion in the anterior commissure and very easily can spread submucosally to involve the pre-epiglottic space, subglottic, and it can track below the thyroid cartilage and then present as a extralaryngeal extension. So lesion extending to the anterior commissure, radiology is mandatory, looking both at axial section as well as sagittal section to look for this subtle extension which can be missed on endoscopic evaluation. So when you look at large series of patients treated with transoral laser surgery, this study is from the Steiner's group, you can see that patients with the T1A glottic tumors with or without anterior commissure involvement, the patients who had no anterior commissure involvement had a 3-year local control rate of 93%, whereas patients with anterior commissure involvement, the local control rate dropped down to 79%. And this has been seen in multiple other studies. The Hoffman group looked into their data and they found that the difference in the 5-year local control rate for patients treated with laser surgery with anterior commissure involvement was 95% versus 71% for patients where anterior commissure was involved. So majority of this study, the anterior commissure extension is not studied in great detail. Whether the anterior commissure extension is supracommissural extension or subcommissural extension is very important to understand, because patients who have a supracommissural extension with a good laryngeal exposure can have a better local control rate. So lesions where the paraglottic space gets involved again has a poor prognostic factor, and arytenoid cartilage extension has shown to have a poor prognosis. Why? Because involvement of the clearance of a disease from the posterior glottis involving the cricoarytenoid joint is very difficult, and even if you attain the oncological clearance, the functional recovery is going to be very, very difficult. These patients aspirate and they are going to have a very significant dysfunctional larynx. Hence, for a lesion where anterior commissure involvement is there, it is very important to see for the laryngeal exposure. If laryngeal exposure is good, you should only contemplate laser surgery for supracommissural lesion with adequate laryngeal exposure. Those lesions, when there is a subglottic extension, those are not ideal candidates for considering transoral laser microsurgery. For a posterior commissural lesion, if there is a significant posterior paraglottic space extension with arytenoid fixation, these are not candidates for transoral laser microsurgery. A previous microlaryngoscopy, a microlaryngeal biopsy has a significant impact on the local recurrence as well. Hence, whenever you see on an endoscopy, if you see a lesion in the free edge of the vocal cord, it is better to consider for a laser-assisted excision biopsy, which serve both as a diagnostic as well as therapeutic modality, rather than embarking on a biopsy and then considering for a definitive treatment. Margins, again, is a very important predictor for local recurrence. Margin is the only one factor which is under control of the surgeons. In vocal cord cancers, the margins are slightly different. So you aim for a 1 millimeter circumferential margin, whereas unlike the other site where you aim for a 5 millimeter pathological margin. So studies have shown that the margin positive rates are up to 50% in transoral laser surgery, but this positivity is usually a false positive. Reason being, when you do transoral laser surgery, these are tiny specimens, and orientation is a key to get the optimal histopathological evaluation. And only margins which impacts the local control is the deep margin positivity or multiple superficial margin positivity, because superficial margin doesn't make much of a difference, because you will be operating these lesions under magnification under microscope, and generally it is very unlikely to have a superficial margin positive. Only when you have a deep margin positive or when there is multiple superficial margin positive, you either consider for re-laser excision or for radiotherapy. So with better adjunct follow-up tools in the form of narrowband imaging, these patients can very well be followed post-operatively, and if at all there is any suspicious finding on narrowband imaging, we can do a narrowband imaging directed biopsies in these patients. So coming to the extent of resection, endoscopic cordectomy. So voice outcomes are definitely going to impact based on extent of resection. The European Laryngology Society has classified the extent of resection from type 1 to type 6. Type 1 meaning subepithelial cordectomy, type 2 is ligamental, type 3 is muscular, type 4 is when you remove the total cord going up to the inner perichondrium, type 5 is extension when you go 5A, meaning when you includes the excision of the contralateral local cord and anterior commissure, 5B when you remove the arytenoids, 5C is when subglottis is removed with resection, 5D when ventricular and false cord is removed, and type 6 is when anterior commissure including bilateral vocal cords with subglottic mucosa are removed. So of which type 1 to type 3 tumors do fairly well in terms of voice outcomes. Even though the immediate voice outcome is going to be bad, when you look at their voice outcomes at 1 year, they fare comparable to that of radiation. When you look at voice analysis, you look at subjective analysis in the form of subjective questionnaires like voice handicap index, or objective analysis as well as the perceptual analysis looking at jitter, shimmer, etc. So there have been studies looking at the voice outcomes in terms of extent of resection, and they found that a type 1 to type 3 cordectomy fare well in terms of voice outcomes, both in subjective as well as objective assessment. So based on the current data, the lesions which are amenable by type 1 to type 3 cordectomy have a fairly good voice outcomes compared to radiotherapy in early glottic cancer. So especially in Indian scenario, cost is a very important factor. So cost, there are two types of cost involved in any treatment. The cost is direct cost that relates to the cost of the treatment in the hospital, and the indirect cost which results from the logistics, travel, food, etc., and loss of pay of the bystander and so on. So when they looked at the cost effectiveness between transoral laser microsurgery as well as radiotherapy, so transoral laser surgery fared to be a very cost effective treatment. So finally, we know that the vocal cord, in terms of vocal cord cancer management, transoral laser surgery has a oncological efficacy equal to that of radiotherapy in a selected group of patients. Voice outcomes are good and comparable to radiotherapy if you do a type 1 to type 3 resection. It has a better organ preservation rate because it is repeatable and cost effective. In addition, the laser surgery is a site specific, means you remove the lesion in millimeter precision unlike radiotherapy, where they treat from the superior notch of the thyroid, cricoid, from the skin to the vertebral fascia. All these cases are done as daycare procedure. All of these patients can be easily monitored with narrowband imaging, flexible endoscopy, and this leads to a shorter hospitalization and treatment time. And we can always keep radiotherapy as a salvage backup option if at all the patient recur. So the treatment decision, like any oncology treatment, is based on disease factor, patient factors, and the infrastructure and the MDT. In disease factors, the most important thing is to evaluate the extent of the lesion. If it is involving the anterior commissure, what is the extent of anterior commissure involvement? If it is a subcommissure involvement or the lesion going to the subglottis, not good candidates for transoral laser surgery. Anterior commissure involvement with supraglottic, with the supraglottic, minimal supraglottic extension, with a good laryngeal exposure are ideal candidates. If the patient is happy with the reasonably all right voice based on his profession, cost, logistics, and patient wishes, all of these have to be factored before treating these patients. So for a lesion with a small lesion in the free edge of the vocal cord, these are the ideal candidates to straight away consider for a laser-assisted excision biopsy, which serves both as a diagnostic as therapeutic option. For lesion in the anterior commissure, which lesion in the anterior third vocal cord, which extends to the anterior commissure, but no significant subglottic extension with a good laryngeal exposure, again, these are the candidates to be considered for the laser-assisted excision of the lesion after explaining the pros and cons with the patients. However, when the lesion is bulky with subglottic extension, significant paraglottic extension, or extension to the posterior paraglottic or the arytenoid, are better treated with radiotherapy and not ideal candidates for transoral laser surgery. This is our data on transoral laser surgery for vocal cord cancer, and my experience is about treating about 50 patients in last 1.5 years. So there are a couple of case capsules just demonstrating how we manage. So this gentleman was a 54-year-old advocate who presented with hoarseness of voice of 4 months duration, was referred by my ENT colleague who did an endoscopy, felt that this lesion is amenable for a excision biopsy. So we did a narrowband imaging, and narrowband imaging showed a type 2 or type 3 pattern. So we discussed the options with the patient. So we can either consider biopsy, if positive, to consider for radiotherapy, or straight away go for a transoral laser assisted excision biopsy. Patient opted for transoral laser microsurgery. We did a type 2 chordectomy. You can see the vocalis muscle. And the extent of resection was from the anterior commissure to the vocal process of arytenoid. So there's no much of charring, and all of these patients do well. So we subject all our patients for frozen section analysis. The biopsy, the frozen section report turned out to be squamous cell carcinoma with a margin clearance of about 1 millimeter in circumferential direction. So this served as a curative option to that patient. So patient just had to come for a couple of days in the hospital and he's disease free. So this gentleman was an 80-year-old who had 2 previous microlaryngoscopy biopsy, and one was a laser surgery which was done at Singapore. So you can see under laryngoscopies, we always subject the patient before laser surgery for an endoscopic evaluation. On endoscopic evaluation with anterior pressure, what we could see is there was a little anterior synecdoche, but there was no significant subglottic extension. So these kind of patients, whenever the exposure becomes a little difficult, so we usually tend to do a vestibulotomy or removal of the false cord. So this was a class 1 kind of an exposure according to the laryngo score, where you had to do, needed an assistant by my fellow to give to get the exposure of the anterior commissure. So we did a false cord vestibulotomy and went up to the thyroid perichondrium anteriorly, and still, like, this is a type three kind of chordectomy where we had to remove a significant part of a muscle for clearance. So this was the immediate post endoscopy on 7th day post-operatively. There is a little bit of healthy slough formation, little bit of cough, and the voice is a bit bad at present. But our speech therapist will work with him. And generally what we see is in a type 1 to type 3 chordectomy, a voice outcome at 12 months is going to be better. So even in non-squamous cell carcinoma pathology, laser helps in a great way for organ preservation. So this was this case was a 60-year-old male who was a pharmacist by occupation. He complained of severe neurological weakness for about a year. He had seen multiple neurologists, and he had a history of voice change for about 12 months. Was evaluated one of my ENT friend. He did an evaluation under anesthesia. So because of the large lesion, he had to do an elective tracheostomy, and the biopsy turned out to be a spindle cell lesion. So he referred this case to us. So you can see that this was the lesion after debulking. So the lesion was in the anterior commissure, slightly going to the ventricle. So we did an imaging. It was a slightly bulky lesion involving the anterior third of the vocal cord with the suspicious paraglottic extension plus minus anterior commissure involvement. So we had counseled this patient for an examination under anesthesia, evaluation under endoscopy to see for our exposure, laryngeal exposure, as well as the anterior commissure involvement. Because it looked like a well-defined pedunculated kind of a lesion, we kind of thought that, okay, this lesion there's a small possibility this patient can be treated with transoral laser surgery. We took a consent for total laryngectomy, and then we subjected the patient for endoscopic evaluation. On endoscopic evaluation, we use a 0-degree and a 30-degree endoscope. You could see that the lesion is pedunculated, it's mobile, and with suctioning of those bleeding spots on the anterior commissure, we could see that the anterior commissure was not really involved, and the exposure was great. So we went ahead in doing the transoral laser surgery. So we could get a circumferential margin, including subglottic margin, of about 5 millimeter in this case. This reiterates the importance of endoscopic evaluation before subjecting the patients for transoral laser surgery. So you can make this decision based on endoscopic evaluation, and accordingly you can plan your excision appropriately. So this was a massive defect. So this is how the defect appeared. So we went right up to the cricoid cartilage, thyroid perichondrium, laterally. You can see the vocal process of arytenoid being exposed. Luckily, this patient had a tracheostomy for us for exposure. So otherwise, we would have had a tough time anyway. Even if the patient was not tracheostomized, we would do a percutaneous tracheostomy in these kind of situations for airway. And you can see the thyroid cartilage. You can see the little spots there in the laser. And this was the extent of resection. So patient. So, but the contralateral local cord was still, we didn't resect the contralateral local cord because it was not involved. So the post-op histopathology report after immunohistochemistry turned out to be a low-grade myofibroblastic sarcoma. So this patient, who was planned for a laryngectomy with proper endoscopic evaluation and planning, we were able to save his larynx. Post-operatively, the patient was decannulated on the 10th post-operative day, and the Ryle's tube was removed on the 14th post-operative day. However, this patient is having significant morbidity in terms of voice outcomes. His voice is very hoarse, but over time, I think with speech therapy, he's going to have a reasonable, good voice for communication. So to conclude, there is no level 1 evidence to decide between transoral laser surgery versus radiotherapy in early glottic cancer. However, patients with T1, T2 tumors without involvement of anterior commissure, since voice outcomes are comparable to radiotherapy with better larynx preservation rate, transoral laser surgery can be offered for a early T1, T2 without involvement of anterior commissure. For patients with T1, T2 with anterior commissure involvement, voice outcome is an unfavorable factor. However, if the patient is not a professional voice user, he's not much bothered about the voice, then transoral laser surgery can be given as an option, but in very selected patients looking at laryngeal exposure and other factors. So finally, to conclude, I would acknowledge my mentors, Professor Shanai, Iyer, Karsten, Vishal Rao, and senior colleagues through which I have learned head and neck cancer surgery, and I'm able to practice this. And we run a course on transoral laser surgery annually in November. I'm not sure whether we'll be able to do it this time around. If not, probably we'll do something at a kind of virtual meeting, something like this. Thank you.
Thank you, sir. Okay, sir. I request all the participants, if you have any doubts, please put it in the chat box. I have some questions from Dr. Vinayak. So the first question is, should the treating doctor make a choice whether to take a decision of surgery or laser by the treating doctor itself?
I think it's a very important question. So the decision is best made by the ENT doctor who first sees the patient. He should be able to really assess and decide which patients will benefit by transoral laser excision directed biopsy, which serves both as a diagnostic as well as therapeutic modality in a single sitting. Rather than if you find a lesion in the vocal cord, doing a biopsy and then referring to a curative treatment, if the
Hello, sir, can you hear us? Hello?
Hello?
Hello, sir, can you hear us?
I can hear you. I can hear you.
Yes, sir. Your voice has been cut in the middle. Could you please repeat your answer, please?
So yeah, it's very important for the treating doctor to make that decision how to treat these patients. How do you decide that? So if the lesion is in the free edge of the vocal cord, it is not bulky, not going to the anterior commissure significantly, there is no subglottic extension. So these are the candidates which are amenable for a curative intent excision biopsies. So they need to consult the head and neck surgeon, discuss and be part of this, working together as a team to get the outcomes. But bulky lesions and other factors which I had mentioned, the other poor predictors, to do a biopsy and then refer to treatment. So the ENT physician should be able to make this judgment.
Okay, sir. Sir, because when you are saying about the consensus of laser versus RT, Dr. Vinayak has two more questions to ask. In that context, is laser better for anticipation of recurrence? And is T2 lesion would be better to treat with laser than T1 lesion?
So the first question, whether the recurrence gets picked up better with laser compared to radiotherapy. That's a question, isn't it?
Anticipation of recurrence is better with laser.
Correct. So for a patient treated with radiotherapy, there is going to be post-radiation edema. And generally when you do an endoscopy, it is very difficult to differentiate between recurrence versus radiation edema. On top of that, you cannot use the narrowband imaging technology appropriately in radiation failures because it is not very clear because the vascularity changes. However, when the patient's treated with transoral laser surgery, so the pickup rates are better because you can use the narrowband imaging wisely and do a directed biopsy. And if at all the recurrence occurs, you have an option to re-laser the patients and still save the larynx. You can try conservative laryngeal surgery if you're skilled enough to do it. And you always have radiotherapy as a backup option. So ultimately, in addition to local control, you have a better larynx preservation rates as well. To answer your second question, whether T1 disease is better to treat or T2 disease is better to treat. It is not just T1 or T2. It is the extent, what type of lesion it is, whether it's a well-defined small lesion, it is what extent it is involving the anterior commissure, whether there is a significant subcommissural extension, whether it's a pedunculated lesion, or whether it's a diffuse lesion. So pedunculated lesion localized to the vocal cord, or even slightly bulky lesions without impairment of the vocal cord mobility, all of these can still be very well managed with transoral laser surgery. There is a beautiful paper written by Peretti looking at what is the reasonable limits of the transoral laser surgery. I think we can share that article. It's a very beautiful article, really telling us where we should do transoral laser surgery and where we should not.
Okay, sir. So the next question is by Dr. Subhash Bhatta. The lesion is extended into the subglottis. Is it possible to take margins by laser surgery?
Yeah. So subglottic extension, if it's a difficult thing to do when the lesion is extending to the subglottis. If it's just extending to the subglottis, you can achieve a reasonable good margin. But the anterior subglottic is very difficult to achieve. And if there is a significant, like a subglottis, subcommissural kind of extension, it's kind of difficult to do it. So very selected cases, free edge of the vocal cord, just going to the subglottis or the free edge of the vocal cord, basically not the subglottis, because subglottis really start about 5 millimeters from the free edge of the vocal cord, technically. But the lesion from the vocal cord just going to the lower border is amenable. Technically, subglottis is 5 millimeters below the free edge of the vocal cord. I mean, that is not ideal cases. Those are bulky tumors, better managed with the radiation or surgery based on the staging and things like that.
Sir, how do you assess the chances of aspiration while planning your TLM?
So it's a very important question. So preoperatively, when we do an endoscopy with narrowband imaging, we can delineate the extent of the lesion. Thereby, we can imagine what kind of a defect we are going to get post resection. Okay, if there is a posterior paraglottic lesion, meaning if there is a lesion involving the vocal process of the arytenoid or the posterior paraglottic space requiring resection of arytenoids, if you touch the arytenoids, there is going to be aspiration. Okay, so only if the arytenoids, intra-arytenoid area is not disturbed in laser resection, just like the last case which I showed, they had some amount of swallowing difficulty, but we were able to remove the nasogastric tube about 10th postoperative day. But they are going to have a poor voice outcomes. You're not going to have a voice outcome equivalent to a type 3 cordectomy. So the voice outcomes is going to be inferior.
Okay, sir. Same question by Dr. Abhimanyu. He was asking, in case there is a tracheostomy, how do you decide when to decannulate or put him on oral feeding?
Correct. So the patients who get tracheostomized we have a policy in our department. So we do a FEES endoscopy. So initially what we do is we look for cuff diff. We usually put a double lumen tracheostomy tube with the outer cannula being fenestrated. We first deflate the cuff. If the patient is tolerating cuff deflation, then we change to a blue tube which has a fenestra inside, and then we cork the tracheostomy tube for at least 24 hours. After which we subject this patient for a FEES evaluation. We look at we try liquid, semi-solid, solid food, look for any aspiration, penetration, and we try our swallowing team works with the patient and tries for swallowing maneuvers. Once swallowing team feels that the patient is safe, after discussing with med and neck team, if they feel that they are safe to start oral diet, they initially start with clear liquids with neck maneuvers, and then slowly, once the patient has adequate intake orally, we remove the nasogastric tube and the tracheostomy tube. Tracheostomy tube is removed based on the findings on FEES, as well as clinical symptoms in the form of cough, anything on food or anything like that.
Thank you, sir. Another interesting question is, in case of you don't have a CO2 laser, and in cases of difficult exposure, in early cases of glottic cancer, do KTP laser has any role?
Yeah. So there are two lasers which are used mainly for vocal cord surgeries: the carbon dioxide laser as well as KTP lasers. The advantage of KTP laser is it's an angiolytic laser, so it get absorbed in the hemoglobin. So it has a better hemostatic ability. But in terms of precision, it is slightly inferior to carbon dioxide. So KTP laser is a reasonably good cutting tool for vocal cord surgery, and it can be tried for vocal cord surgery as well. But the KTP laser has more advantages in carrying out surgeries of the supraglottis, base of tongue, where it is a really vascular kind of lesion. When it is a non-squamous lesion, KTP laser fares better for a supraglottic, base of tongue, and oropharyngeal tumors because of the better coagulation property.
Okay, sir. Another little interesting question from Dr. Sachin. What is the cost involved of the instruments and any other capital costs?
Right. So very important question to start the program.
Yes,
so its infrastructure is a very, to run this program, technically, like all ENT surgeons are well trained to do a laryngoscopy, suspension, use of microlaryngeal instruments, that's fine. But the cost of the laser equipment is a setback. So all of the centers will have a microscope, will have microlaryngeal instruments, will have laryngoscopy. Only thing which stops them to do the transoral laser surgery is the carbon dioxide laser machine, which costs about 50 to 70 lakhs if you're going for only micro manipulator one without fiber or other handheld attachment. Unfortunately, carbon dioxide laser mainly is used only for vocal cord surgeries. But having said that, there are a huge range of applications of carbon dioxide laser. So the previous center where I was working, we had the laser machine for demo, KLS Martin laser machine for demo for a week. And believe it or not, I performed 4 transoral laser surgery in a week when the machine was there. So meaning is, there are enough cases to do it. It's just that more understanding of this technique, more using of this technique is important for wider use of this. So it's only a matter of time that this laser machine is going to be across the centers. And I think cost is a factor because it can be used only for one subsite. But as a group, like if you are in a place, like if you are in Hyderabad and you want, you talk to the group of ENT surgeon in the around Hyderabad, and you as a team work together, invest, and it may be practical to run this program effectively. Only thing is the cost of the laser, it's around 50 to 70 lakhs.
Okay, so thank you. So the next question is by Dr. Subhash Bhatta. How do you prevent the anterior glottic web after cordectomy? What are the measures you take? Right.
So anterior glottic web is very difficult to manage. So generally, if there are bilateral vocal cord lesion, okay, and if the bilateral vocal cord lesion on an NBI is it looking like a type 3, type 4 pattern. So what I would do is I would stage the procedure. So staging is one way to prevent it. So you do a higher suspicion on an NBI lesion first, and then after about 6 weeks, come back and address the opposite side. And this has been published, and it is oncologically. When you have a lesion which is going to anterior commissure.
Your voice has been cut. Can you just repeat it one more time?
Now is it better?
Yes, sir.
So if the lesion is involving bilateral vocal cord and it is superficial lesion, with the help of NBI assistance, you can stage this lesion. The bad NBI you do first and come back after 6 weeks and do the next one after 6 weeks. And this is oncologically proven. But if you end up having a extended resection involving both vocal, it's very difficult to prevent the webbing formation. There have been theoretical mitomycin, silicone, keel, and all of those, but I have no experience doing that. So best is if this is a superficial lesion, better to stage it. If at all the web happens, you can re-laser it on a later date. I think that's the way I would deal it. But I would, yeah, that's the way I would deal it.
Okay, thank you, sir. So next question is by Dr. Joshna. How do your transoral laser surgery case selection will go during this COVID crisis?
Right. So that's a very, very important question. So this procedure is has a high risk of transmission. So in a COVID crisis, since the oncological outcomes are quite similar between surgery and radiation, I would counsel the patients more for a radiotherapy rather than considering for transoral laser surgery. However, but having said that, I will explain all the positives and negatives for both transoral laser surgery and radiotherapy. And it's always I'll leave the judgment to the patient. Even if the patient would still want to get a transoral laser surgery, I would still contemplate to do it, but I would take the protective measures. So I would restrict the number of the team in the operating team. I would use a smoke evacuator to perform the surgery. And I would just use a routine protective equipments to prevent risk of contamination to the team and myself.
Okay, thank you, sir. So one more interesting question by Dr. Abhimanyu. He is asking information regarding management of supraglottic lesions by trans TLM. Especially when would you consider doing, what kind of lesions do you consider doing involving the pre-epiglottic space? Yeah.
So supraglottic tumors, it's a different ball game altogether. You need to, as I told, supraglottis has, it's very vascular, number one. Number two, supraglottic has higher tendency for lymph nodal metastasis. It is in this case, in supraglottic.
Hello? Hello?
Hello, can you hear me?
Sir, your voice got cut. Okay,
now?
Repeat from the beginning.
So for a supraglottic tumor, as I told, it's a different subsite altogether. It has high lymphatics. You need to treat the primary as well as the lymph nodes. The current standard for a supraglottic tumor is to consider chemoradiotherapy or radiation depending on the stage. For a lesion which is extending to the pre-epiglottic space, for a squamous cell carcinoma, absolutely it is not advisable to do a transoral laser surgery. But for a limited lesion, if it's a superficial lesion, pedunculated lesion sitting on the epiglottis, not extending to the pre-epiglottic space, not significantly extending to the vallecula or the base of tongue, those can be considered, but you need to address the primary as well as the neck node in the same setting as a prophylactic neck dissection, even if it is not involved radiologically. So if you are using carbon dioxide laser for a supraglottic lesion, you should be, you may need a monopolar or bipolar cautery for hemostasis, or laryngeal clips, especially for to deal with the superior laryngeal pedicle to reduce the hemostasis. So for a pre-epiglottic space, it is not advisable to do a transoral laser surgery. It is better treated with chemoradiation. If it was a non-squamous cell carcinoma, supraglottic tumors, at our center, we would prefer to consider transoral robotic surgery over laser surgery because of the better, better magnification, angle telescope, and wrist maneuverability of the robotic arms.
Okay, sir. Sir, some of the people are asking questions about NBI, and especially Dr. Ratan Shetty has been asking you to describe the NEES classification.
That knee classification is a very difficult classification to remember. Okay, so generally what you do is I have a knee classification on my phone. So whenever I look at the NBI, so what is important in NBI is to stay very close to the lesion. So it is when you're interpreting the NBI, the endoscope has to be very close to the lesion. And based on the subepithelial vascular patterns, I can send it across. I don't have it on the top of my mind. Normally what I do is I look into the pattern and then correlate. Type 5 onwards, it is 5 is considered to be more for a malignant change.
Okay, sir. So one more interesting question is, this is a controversy from ENT side also, sir. So generally growth on the vocal cord with mobile cords, biopsy will be done as a diagnostic modality in the peripheral hospitals or referral hospitals. But by the time the patient comes, can we do CO2 laser for T1 or T2A lesions, T1A or T1B lesions? Because the already when the time biopsy is taken, there will be no lesion seen for the laser surgeon. And second thing, how much is it cost effective?
If you look at the predictors for local recurrence for patients treated with transoral laser microsurgery, previous MLS, unplanned MLS excisions is one of the very significant factor for local recurrence. So you have to understand one fact. So when you do a DL scopy, like a biopsy for a very small lesion, 30% of these lesions are curative. That is, you do a DL scopy and we do a laser excision, 30% of patients won't have tumor. So if you do a DL scopy and send them to a center, they may get radiotherapy unnecessarily in about 30% of patients. And second, when they come back on the table for a laser excision, the extent of resection is going to be more than what you had done primarily. As a result, the functional outcome also comes down. And we always counsel our patients when the patient comes with a biopsy and then we do a laser excision that about 30% will have a negative biopsies. So it is better to consider for a excision biopsy rather than doing a like an oncological excision biopsy under control rather than doing just a DL biopsy and then referring those patients, because it can be treated with just like a single modality in a day. So it's very cost effective.
Okay. Sir, one more little out of the context but interesting question by Dr. Subhash Bhatta. He was asking your experience with cricoid chondrosarcoma, because they had one case of cricoid chondrosarcoma which they tried to operate with laser with led to bleeding, and they had to do the tracheostomy to save the patient. So they are asking you any experience on cricoid chondrosarcoma.
See, chondrosarcoma arises from the cartilage where the name goes, and generally, since when the patient presents to us, because this cricoid carcinoma is generally present in a slightly like a bulky stage. Okay, so laser can cut the cartilage, but it is very effective for soft tissue, because the principle in which it works, it gets absorbed by water, and the steam effect and the cutting and the desaturation of protein, it is very good cutting tool for soft tissue with water content in it. However, cartilage can be done, but for a chondrosarcoma, which is having it's a high grade tumor, it is better to consider for an open, in my hands, I would consider for an open surgery than for a laser. Because generally chondrosarcoma, it would have presented early on the cartilage being high grade, I would consider for open surgery rather than laser.
Okay, sir. Sir, one more good question is from Dr. Vinayak. Does laser have any implication on biopsy report? Yeah.
So laser does have implication on biopsy reports. So because laser is nothing but a cutting tool, so there will be carbonization. There is going to be shrinkage. As shrinkage, so it is very important to. Hello, Bhargav. So yes, it's very. Yeah. It is very important to orient the specimen appropriately. We don't have any problems for superficial margin. So I am not worried if the pathologists tell this margin is superficial. Intraoperatively, if I under microscope, if I feel that I have got it out completely, I am only worried about the deep margin as well as the anterior commissure. So if at all the anterior commissure comes positive, I'll do a free biopsy from the free edge of the whatever remnant on the patient side. Deep margin comes positive, I'll go ahead and do a relaser excision. So laser surgery does have an impact in analysis of the specimens in microscope, but proper orientation and good communication with the pathologist is very important to get the best results in transoral laser surgery.
Okay, sir. So the next question is again from Dr. Ratan Shetty. Do you do a stage and neck dissection for supraglottic carcinomas?
So, yeah, if you contemplate to do a supraglottic cancer excision or a hypopharyngeal excision, it is advisable to do a staging neck dissection as a staging prophylactic neck dissection.
Okay, sir. So the next question is from Dr. Sujan. When CO2 during CO2 laser surgery, how do you manage bleeding in type 3 or above cordectomies?
Right. So that's a very important, a very practical question. So we come across this in a routine. So what is important is whenever you have a lesion going to the anterior commissure, that's when it's going to have one spurter. The other spurter is going to be in the posterior commissure region. So what we use is, we generally use a monopolar suction cautery, and we keep the setting is around 15 to 20 to maintain the hemostasis. If at all we come across anterior commissure or this thing, certain situations where the bleeding is not controlled with the suction cautery, we resort to a bipolar microlaryngeal forceps for hemostasis. Small bleeds can be controlled by using a neuropathy with the lignocaine with adrenaline. That helps for very small little ooze, it helps. But for spurters, you use a suction cautery or a bipolar cautery.
Okay, sir. So one important question is, in case of aspiration during limited supraglottic lesion like an epiglotectomy,
how do you deal with it? Is it?
Yes, sir.
So as you know, there are 3 tires, and epiglottis is a very significant protective protection for the airway. So resection of the epiglottis does affect significantly. So how do you deal with it is, we do post-op speech therapies. So we need to do the strengthening of the tongue muscle. You do the Masako maneuver, and you advise the patient for the supraglottic and supraglottic swallows to help them learn the technique through which they channel it to the right way, and also increasing the pharyngeal pressure. So our speech pathologists work with them, train them, and also maneuvers in the changing of the position of the neck also helps so that the food gets channeled along the less affected side.
Okay, sir. So one more question is again about anterior commissure, sir. Can we do the TOLR for this anterior commissure, transoral laser resection for anterior commissure involvement?
So most important determinant, as we discussed, for an anterior commissure involvement, number 1 is when you do a laryngoscopy under anesthesia, your exposure has to be adequate. Generally, for an anterior commissure, just with suspension laryngoscopy, it is very difficult to achieve the exposure. Invariably, you need to do an anterior pressure on the thyroid lamina, center as well as lateral. So it's like it becomes a forehand approach, and the most difficult job is of the surgeon who is helping you with the procedure. Okay, so our fellows have a very tough job when they do the anterior commissure. They will be cursing me because I am seeing under microscope they had great difficulty in getting that exposure, because that anterior pressure is very, very important to get the right thing. So for anterior commissure lesion, the exposure as well as the extent. If it's supracommissural, then it is amenable. But if it is subcommissural, it is not. Those are not ideal candidates for laser surgery.
And sir, I remember you doing a cordectomy in the false cord also in anterior commissure to get the exposure and to remove the perichondrium also, which in many cases which we have resisted you.
Correct. So that's another important thing. So when you have an anterior commissure, you're not getting a visualization properly, but it's a very superficial lesion. You can go to the PTL of the epiglottis as well as the anterior false cord to create a window to get the third dimension. So you can go up to the perichondrium, and then you can get the lesion with the which is oncologically safe. That assessment is very key.
Okay. One more important question for the beginners from Dr. Abhimanyu. What do you recommend piecemeal? What do you recommend the piecemeal resection versus unblocked resection?
Yeah. So the work done by Steiner has proven that piecemeal resection is oncologically safe, and it is practiced for little bulky lesion. So it is once you in your learning curve, once you start doing your T1s, like superficial ones, then you can embark on the piecemeal resection for a bulky lesion. not with all the factors which I had explained. So you do a transtumoral cut, so it's going to bleed a little bit. So you may sometimes go for a switch between focused and defocused to control hemostasis versus cutting. See the depth, because when you cut the laser through the tumor, there is charring. That's how you differentiate between normal tissue as well as tumor. By doing a transtumoral piecemeal resection, your depth is going to be more precise, and it can be tried, but it's always better to do it once you have finished your learning curve on doing a smaller resection, and then you can try the piecemeal resection for little bulky tumors.
Okay, sir. One question. I think vocal cord fixity. What is your take it on table? I think it should go to the RT according to me, because the staging changes immediately once the fixation occurs.
Correct. So vocal cord fixation most often can be picked up preoperatively, so that automatically upstages the tumor into T3, and intent of treatment is chemoradiation. However, even for T1, T2 lesions, if there's a posterior lesions, it's very important to intraoperatively check for the arytenoid mobility. So that forms a very important maneuver before carrying ahead with the surgical procedure. So you have to evaluate the anterior commissure, you have to look at the posterior commissure, you have to look at the subglottis. With the angle telescope, you have to look at the ventricle. And with the anterior pressure, you need to look around the lesion properly under microscope, see if you can get around the lesion and get it out with margin clearance, and only then go ahead with the curative intent surgery.
Okay, sir. And one more very important and interesting question, sir. How do you manage biopsy suggesting dysplasia for lesions in the anterior 1/3?
Correct. So biopsy suggesting dysplasias, I would like to see whether it's a localized dysplasia or a diffuse kind of a dysplasia on a flexible endoscopy. Then what I do is I do narrowband imaging on all these patients. And if at all on the narrowband imaging, I find a suspicious kind of a pattern, okay, then I would go for a laser assisted excision of that suspicious area. If it is involving bilateral vocal cord, I would address only one vocal cord first. And then post-operatively, I follow up them with like saline nebulization, all of those, and again follow them with NBI. And based on the NBI report, I would make my decision on surgical excision. So whether it's localized or diffuse, involving one vocal cord, both vocal cord, and I do a NBI directed excision.
Okay, sir.
And I may have to stage it.
Okay, sir. And there are multiple questions, sir, asking what do you do in case of difficult exposure in all the types of lesions, like small or big or anterior commissure lesions or anterior 1/3 of the cord. In case of a very, very restricted mouth opening, you have as a 3 centimeter or 2.5 centimeter isthmus or difficult neck extinction cases, how do you manage those kind of patients for laser?
Correct. So the patients with reduced mouth opening, you cannot, it's very difficult to perform transoral laser microsurgery. So minimum mouth opening required is about 3 to 3.5 finger to carry out this procedure. Most important factor is the laryngeal exposure. If you're not able to get the laryngeal exposure, with that kind of a mouth opening, I guess it is very difficult to do a biopsy as well. So we have to contemplate on doing a flexible, like a bronchoscopy assisted biopsy in that situation. So mouth opening, reduced mouth opening, those are not candidates for any transoral procedures. Maybe robotic, laser, those are not candidates for those surgeries.
Okay, sir. As of now, we have concluded. All the questions are answered and everyone is happy with this. Many congratulatory messages are coming in the chat.
Right. So thanks.